Welcome everyone to the April 28th COVID-19 clinical care rounds focused on critical care, life-saving treatment and operations. My name is Richard Hunt. I'm an emergency physician who serves as Senior Medical Advisor, the National Healthcare Preparedness Programs in the Office of the Assistant Secretary for Preparedness and Response at the United States Department of Health and Human Services. The purpose of these rounds are peer-to-peer real-time sharing of COVID-19 critical care challenges and successes in patient care and operations. If I'm an intensivist preparing to care for many COVID-19 patients, the clinicians I really want to learn from are those clinicians who have the most experience. This is a voluntary public-private collaboration. Thanks to the multiple professional organizations who have collaborated with these rounds. These are not intended to be sharing of clinical experience and not recommendations or guidance. These clinical rounds with ECHO you are now participating in are focused on clinicians sharing their successes and challenges in patient care and operations with other clinicians. Appreciation is expressed to NETEC, the National Emerging Special Pathogens Training and Education Center, for their support with these rounds. NETEC has webinars that complement these Project ECHO COVID-19 clinical rounds, and you'll be hearing a bit about that further. Thanks to Project ECHO, Dr. Bruce Struminger and his team for the peer-to-peer learning platform we're using for these rounds. Upcoming ECHO COVID-19 clinical rounds currently are all US noon Eastern time. On Thursday, April 30th, noon Eastern time, we'll have clinical rounds on emergency department patient care and clinical operations. Our current schedule for rounds is Mondays, EMS, Tuesdays, critical care, Thursdays, emergency department. We are currently planning on, and this is tentative, but we're planning on a special session on long-term care facilities, patient care, and clinical operations this coming Friday at noon Eastern. When we send out announcements for upcoming rounds, you'll frequently see that we don't have all the speakers identified. They are TBD since we work to identify speakers just in time given the rapid changes and experience with the pandemic. For ECHO clinical rounds to date, we've had participants from all states and many countries, predominantly physicians, nurses, and EMS clinicians. We've noticed an increase in participation by clinicians from other countries and appreciate their participation. We're interested in making this more interactive by continuing to engage expert discussants, and we use crowdsourced polling, and recently we've started using some polling function that you'll learn about a little bit in the very near future. We have many pages of questions. Actually, the numbers of questions are starting to diminish compared to when we started, with over 550 questions for our first session. And we apologize in advance that we're not able to cover all those questions. We do pick out major themes and try to address those. With that, I'm going to turn this over to Dr. Bruce Struminger with Project ECHO.
Great, thank you, Rick, and welcome to all our 400+ attendees and to our panelists and speakers today. I'm going to share a few slides just to briefly go over some housekeeping items. And the first one is you'll notice a Q&A function down in the bottom of your Zoom toolbar. So please use that to enter questions and comments regarding the presentations. As Rick said, we may not be able to get to all of them, but we'll try to get to a number of key questions that come up. Please reserve the chat function for questions regarding any technical or logistic issues. We will be doing one crowdsourced question, and we'll want you to put your response in the chat in relation to that. This session is being recorded, and your attendance is consent to be recorded, so thank you for that. The slides and a link to the video recording will be shared after the session via email with everyone who registered. Also, the links to the recordings and presentations are on a web page on our University of New Mexico Project ECHO site, and we'll share a link to that with you in the chat. There will be CME and continuing professional development credits available through the University of New Mexico. There'll be a link in the chat at the end of the session. There was also a link in the announcement sent out in the last few hours. So you will have up to 48 hours to take the brief survey, the CME survey, which gives us feedback so we can continue to improve these sessions and respond to your needs. And those are my basic housekeeping items. With this, I'm going to pass the microphone to Sharon Van Airdsdale with NETEC. Sharon.
Bruce, good afternoon, everybody, or good morning if you're on the West Coast. My name is Sharon Van Airdsdale. I'm the Program Director for Emory Serious Communicable Diseases Unit. I'm also the Director of Education for the National Emerging Special Pathogen Training and Education Center. And as Rick mentioned, really happy that we're able to partner with ECHO and provide more in-depth webinar series based off of topics that come up on these clinical rounds. So we do have 2 upcoming webinars that we already have posted on our website. One is ethical issues in pandemic response, so the triage and beyond. And then the use of proning and implications for your patients and your team. So if you're interested, please visit netec.org and you'll find registration links there. Thank you.
Great, thanks, Sharon. And Rick, I'm going to hand the mic back to you to cover the AAMC clinical guidance repository.
Thanks. This slide is just to share with participants that indeed there is a clinical guidance repository that the AAMC houses. You see the website there, and want to make sure that you have that available to you. With that, I'd like to go to our first interactive question of the day. This one is basically a crowdsourcing pearl, and we would really appreciate your answers in the chat for this. So the question, this is kind of a multi-pronged question. What's been your experience with proning? And have you developed any standard practices for proning? And if yes, what are they? And then what state or country are you in? There's been a lot of discussion about proning since we began these rounds a few weeks ago, and want to see where we are with that in the country today and in other countries today. So please answer in the chat room. Don't be shy. The information actually is there for all to see, and I think it's a great way of learning how your colleagues are working with patients with respect to proning. With that, I'm going to introduce our panelists and speakers are going to briefly introduce themselves. If you could all the panelists and speakers go off mute, and we'll just go around the Hollywood squares very quickly with just name, title, and affiliation, please. Starting with Allison.
Good morning. I'm an assistant professor at the University of Chicago.
Mark.
Morning, I'm a intensivist at Emory University and the ECMO program medical director.
Melissa.
Hi, my name is Melissa Brunswold. I'm a trauma critical care surgeon and the ECMO medical director at the University of Minnesota.
And Sharon.
I already introduced myself, but I'm Sharon Van Airdsdale, Program Director for Emory Serious Communicable Diseases Unit and the Director of Education for the National Emerging Special Pathogen Training and Education Center.
Paul?
Paul Bittinger. I'm an emergency physician and Director of the Center for Disaster Medicine at Mass General Hospital in Boston.
Thanks all for joining us. With that, I'm going to turn this over to our first speaker, Dr. Allison Dalton. She's an assistant professor in the Department of Anesthesia and Critical Care at the University of Chicago. In addition, she's the director of the Anesthesia Critical Care Fellowship and associate director of the Anesthesia Residency Program. Allison, please.
First of all, thank you so much for allowing me to come and speak today, and appreciate the chance to be able to share our data. In addition to being an anesthesiologist and a critical care doc, I've actually had the privilege of being in our COVID ICU last week and a few weeks ago, taking care of these special group of patients. As many of you, I'm sure you have seen, the data really shows that the hardest hit population of patients really fall between the ages of 50 and 80. Although our specific population at the University of Chicago has another 20% of patients over the age of 80 that we're taking care of within the ICU. Since standing up our first COVID cohort unit on March 20th, we've taken care of 154 patients at the University of Chicago in our 4 COVID ICUs. The mean age is very similar to that we have been seeing in other places, and we see about 50% of our patients being male, 50% about being female. Given that we're located on the south side of Chicago, we do have a high preponderance of patients who are African American, with nearly 90% of our patients falling into this demographic. We also are seeing a significant number of comorbidities. Our mean BMI for our patients falls within the obese range. We see high rates of hypertension, diabetes, pulmonary, and kidney disease. Our initial plan when we opened our unit was much as other infusions that are doing, which was early infusion of our patients. One patient required more than 5 liters of oxygen, they were for the next year. They were intubated at this point in time. And what we're doing now is actually utilize more non-invasive ventilation. Up to about 2/3 of our patients today have.
Hey, Alice,
Yes.
maybe your audio sounded very patchy. Were other people, did it sound good, or was there a problem? Rick, we can't hear
It's
you.
Melissa. I'm having a hard time hearing.
Yeah,
I apologize. Let me see if I can optimize that a little bit here.
great.
Are you able to hear me now?
Yes, much better. So whatever
Much
you're
better.
doing, thank you.
Sure.
Maybe if you could go back to the beginning, if you could go back a minute or so and
Sure.
carry on. Thanks.
So as far as our experience here at the University of Chicago, we were originally intubating everyone early. Once you reached approximately 5 liters of nasal cannula, you were transferred to the ICU and endotracheally intubated. Since that time, we've adjusted our practice and are now offering non-invasive ventilation to the majority of our patients. As you can see here, to date, about 2/3 of our patients have received high-flow nasal cannula, 5% have received non-invasive ventilation with BiPAP or CPAP, and we've had 21 patients utilizing the helmet non-invasive ventilator. In addition to that, we've been proning many of our patients. Of all of the 150 or so patients that have come to us, about 1/3 of them have been proning. And of those patients who are proning, about half of them are doing so while they're on high-flow nasal cannula and still awake, not intubated, not sedated. In about our month of experience, we're seeing our mortality from our ICU patients of about 20%. To date, we've had about 60% of our patients discharged from the ICU, and nearly half of them have actually been discharged from the hospital. The use of non-invasive ventilation, we've been able to do this due to some foresight by our institution. Early on in the process, they were able to convert 2 full floors of our institution to negative pressure floors. And in addition, we've had adequate amount of PPE in order for us to provide for our patients within these units. In order to be able to do things like high-flow nasal cannula, we've needed this in order to decrease the risk of aerosolization to our providers. And because of this, we've also been able to utilize helmet ventilation. The helmet actually consists of a transparent polyvinyl chloride hood and a latex-free neck seal that are situated within this plastic disc. In this unit here, we actually have multiple inspiratory and expiratory ports. This here is the polyvinyl chloride hood and the neck seal here. And you can see on the side of the hood is the inspiratory port that actually has a plastic covering that allows for a one-way valve. And on the hood here, we have the expiratory port. There are additionally accessory inspiratory and expiratory ports that can be used, and you'll see this as an example in the video that I'm about to show. And finally, on this disc, there are hooks that allow for securing the device with some padded arm braces after the hood is fully inflated. In 2016, Dr. Bhakti Patel, one of our medical intensivists at the University of Chicago, performed a study looking at the helmet versus face mask, non-invasive ventilation, and the rates of endotracheal intubation in patients with ARDS. They actually had found that in patients with ARDS, they were able to decrease the number of patients who were endotracheally intubated using the helmet as compared to using a face mask ventilator. In this video you're about to see here, Dr. Bhakti Patel and Dr. J.P. Kress show how to assemble the helmet as well as utilize it for patients.
The helmet interface for delivery of non-invasive ventilation is a transparent hood that covers the entire head of the patient. A soft rubber collar seals the hood at the neck. First, measure the neck size of the patient.
Sorry to stop you, Allison. We're not able to see your video. If you don't
The
mind
collar size
resharing
guide.
your presentation screen.
Absolutely. New share. Forgive me. And I'll restart the video. Forgive me for that.
Determine
There we are. Let me know if there's any problems with the video.
the helmet interface for delivery of non-invasive ventilation is a transparent hood that covers the entire head of the patient. A soft rubber collar seals the hood at the neck. First, measure the neck size of the patient. Using the collar size guide, determine where to cut the rubber collar to ensure a tight yet comfortable seal at the neck. Attach the rubber collar to the plastic inner ring of the helmet. Now attach the inner ring to the helmet's transparent hood and ensure a tight seal. Attach the ventilator's inspiratory and expiratory tubing to the port sites on the helmet. Set the ventilator to pressure support mode. To improve patient ventilator synchrony, adjust the rise time to 50 milliseconds and change the end flow to 50%. Stretch the rubber collar of the helmet and place over the patient's head. Once the helmet is fully inflated, attach felt arm straps to the front and back of the helmet. This secures the helmet's position on the patient's head. The helmet pressurizes in seconds. PEEP is increased to achieve adequate lung recruitment and oxygen saturation. Notice that at this level of PEEP, there is no detectable leak in the ventilator circuit. FiO2 is also titrated to a non-toxic level to achieve oxygen saturations above 90%.
In addition to using this type of non-invasive ventilator or ventilation with a ventilator, you can also use this device just via wall oxygen. Forgive me, I'm going to pull our slides back up here. Are you able to see my slides again? Great. So we've actually been using this device with wall source oxygen and air in order to prevent necessity of using ventilators, especially if we were to hit a large surge. As you can see here on the picture in the middle, we have tubing hooked up to both the inspiratory and the expiratory ports of the hood. On the inspiratory port, we have extension tubing that's then hooked up to a multi-adapter that allows for the input of multiple sources of wall oxygen and air. On the expiratory port, we have, again, some tubing connected to a viral filter and a PEEP valve in order to deliver PEEP into the system. In order to titrate our oxygenation and our ventilation, we start with the patient on the helmet with multiple oxygen flow meters, delivering a total of 80 liters of flow at 100% FiO2. As we deliver the FiO2 of 100%, we can then up titrate our PEEP to get goal saturations between 88 and 90%. As the patient's saturations improve, or as they improve over the course of time, we can then use this table in order to down titrate both the flow as well as FiO2 in preparation for removing of the helmet. For patient comfort, we've also added a bubble humidifier to our low flow oxygen flow meter in order to prevent drying, especially of the nasopharynx. And finally, we can avoid hypercarbia by using these high flows, greater than 30 liters per minute, to prevent rebreathing of the air within the helmet itself. Using non-invasive techniques, over half of our ICU patients have avoided intubation to date. This has also been associated with the difference in mortality, although many of the other baseline characteristics are very similar. In fact, when looking at our Kaplan-Meier survival estimates, if we start looking around the 14-day or 2-week portion of this curve, we see that the mortality for those who have never been intubated is roughly about less than 10%, compared to those who are intubated with a mortality of around 30%. While we seem to have had success with non-invasive ventilation, we still have the challenge of determining which patients will ultimately require intubation. We have also found that for those patients requiring high amounts of flow and high FiO2 via high flow and helmet non-invasive ventilation, the intubation attempts are precarious. They're fraught with episodes of desaturation and even bradycardia. Ideally, we seek to set up a system where we'll be able to identify which patients will ultimately fail non-invasive ventilation and go towards early intubation in these patients, while avoiding intubation in the patients that will have success with things like high flow nasal cannula, BiPAP, CPAP, and helmet non-invasive ventilation. I want to give a big thank you to all the residents, fellows, nurses, our respiratory therapists, the tireless efforts that they've been putting in both in the ICUs and outside. I also want to thank my colleague with whom I've been in the trenches and also with whom I've been working on analyzing our data to determine what the best path is to taking care of these patients. And thank you to all of you for allowing me to share our experience and our data from the University of Chicago.
Thanks very much, Allison. It was a wonderful presentation, and the video was great. A lot of questions that I have, but a couple of them off the top. I noticed that the helmet video, correct me if I'm wrong, but I think it was like from 2016. So it's not like this strategy, at least from what I could tell, is like this is a brand new thing for COVID. So the question is, if I'm correct in that assumption, so was it like right away when these COVID patients came, really with considerable ventilation challenges, somebody said, "Yep, we're going to use the helmets and we're off," or was this sort of like a learning curve and well, maybe that'll work? I mean, how fast did you jump into this?
So we've phased in the use of the helmets over the course of time. Like I said, early in our experience for the first week or two, we were really intubating everyone once they were greater than 5 liters. But with still Dr. Bhakti Patel and Dr. J.P. Kress, who did the original study back in 2016, still on staff at the institution, they thought that this would again be a good opportunity to be able to use the helmet, especially to avoid some of the aerosolization issues that we potentially were seeing with our high flow nasal cannula. We've also seen that what the helmet can offer that high flow nasal cannula hasn't been able to is that many of these patients require about 10 centimeters of water of PEEP in order to really increase their FiO2. So it's been a very helpful tool in order to give a little bit of PEEP to our patients as well.
I have a follow-on question. Is that was going to be my question. How high have you been able to push the PEEP with the helmet? Is it to 10 or is there a higher number?
Typically, we've been using about 10 centimeters of water is typically what most of our patients have needed. We can push it as high as 20 centimeters of water and the seal holds in place. But the majority of our patients settle out somewhere usually between about 10 and 15 centimeters of water when the hood is first placed.
Is it otherwise uncomfortable higher than that? Do they have difficulty with ears and things like that at a higher number?
Sure. So all of our patients are actually fitted with earplugs prior to the helmet going on, just because of the high flow as well as the PEEP there. We have not seen any damage to date, more of an annoyance with the noise volume. The majority of the time, the reason that we stop at 20 is that's as high as our PEEP valves tend to go. And also I have some concerns that if you're requiring FiO2 of 100% and a PEEP of 20 on the helmet, many of our patients by that point may show some signs of tiring out, and we'd move towards endotracheal intubation.
Someone on the question and answer asked if there's a way to quickly remove it in the case of emergency, or if the patient panics, if they vomit, for example. Is there some way to quickly remove it in a safe way without exposing everybody?
Absolutely. There's been a few different of our patients who have liked the hood more than others. And the patients can actually remove their hood on their own if they so choose. All you need to do is essentially stretch that rubber collar and pull the hood off from over the top. Ideally, if you're doing it for a planned intubation, you'll disconnect the inflow from the wall prior to removing the hood, but it can be done very safely over the course of a couple of seconds.
Thanks, Allison, for your presentation, and I'm sure many questions, more questions will pop up. Fascinating presentation. Let me move now to our next speaker, Dr. Mark Reedy-Scheibel, Assistant Professor of Anesthesiology and Critical Care Medicine and the Medical Director of the program at Emory University Hospital in Atlanta. Mark has been with us before, been a panelist, been a speaker a couple of times before. He along with Melissa were the pioneers with our critical care series. So Mark, I'm gonna turn it over to you to focus on a real big challenge that we have with these critically ill patients.
Thank you, Rick. I am, again, I'm gonna, hold on, gotta get this to advance. There we go. I'm just gonna give my usual caveats that your results might vary depending on your location and your resources. I'm actually gonna talk quickly about two different things. One is kind of, in addition to our statistics, just a quick notes on two of the new things that we've discovered, one in pulmonary and one with heme. Just our stats through April 17th. We just we're working on publishing these, but they are also available in preprint at the link on the bottom. I'd say we've currently had about 29% mortality with admissions to the ICU. And I would say, that's with the caveat that our ICU admissions, are generally when they've gotten to a point of needing either heated high flow nasal cannula or intubation. I'd say, these statistics are inconsistent with other area hospital systems that we've asked about. And, I'm highlighting this in the kind of current controversy, over, a lot of the data that's being published, especially out of New York, although even the more updated New York mortality statistics are generally in this range. So I just think, it's important to highlight. Again, I would say, even on mechanical ventilation, that we have had a 76% survival rate. And now I'll just kind of point to what's new. The things I kind of wanted to bring up just as for people to investigate, and I would point to two papers, or one paper and one website at the bottom of the screen there, which gives a little more information about this, and to, it's worth reading to kind of digest it. But we're really starting to appreciate that there are two phenotypes within the kind of COVID lung. One is and the surprising part is this, that we've kind of noticed before, that there's this normal compliance that we're seeing. And to a lesser extent, we're seeing fewer patients with the low compliance that we usually associate with ARDS. But this is important because we've been kind of traditionally treating people like they have ARDS, and maybe that's not the approach we need to be taking with everyone. In the normal compliance now, we've started to recommend, to use a lower PEEP approach, higher FiO2 maybe than we would with ARDS. Proning and paralysis, I think we've all noticed that they've been variably successful. And again, it might be because some people have one phenotype or the other. So in general, we don't expect for proning and paralysis to be as effective. We would expect pulmonary vasodilators to be more effective, or inhaled ones. and then we reserve the kind of more traditional ARDS management for the ones which have demonstrated compliance problems. The next thing, just to again kind of highlight is, and I think this is starting to get a little more attention, but I've been kind of hammering away at it, is this hypercoagulability phenomenon. It's becoming increasingly evident that this is probably at the root of a lot of the fundamental pathology of COVID. We noticed early on that the hyperfibrinogenemia and a low AT3 often, but even with normal AT3, they were heparin resistant. Their blood, we've now kind of done viscosity testing, and it's quite high. In addition, we're appreciating now that doing TEG and ROTEM, this impaired fibrinolysis. The upshot of this is that we've seen a lot of clotting of lines, CRRT, so increase in pulmonary dead space, PE, MI, stroke, the things we would expect from clotting phenomena. And remarkably, this is happening through therapeutic heparin, and even we've had some events through therapeutic argatroban. So this is a serious problem. We don't know exactly what to do with it yet. We are trying a number of things. We have a pretty aggressive protocol for anticoagulating people based on both their D-dimer and their evidence of clot, and we carry this over once they've been discharged. And we're also following them up for up to 6 weeks in our heme clinic, and this is for just about all of the patients at this point. We're also considering some more extensive therapies for people who continue to fail therapy, including continuous TPA infusions and a plasma exchange. We don't have much data to report back yet, but we expect to have some soon. And all of these things are on our updated guidelines site, on our internet site. And additionally, we've also posted them on the AAMC. So, just my final thoughts from the, last 3 weeks is that, again, supportive care remains our #1 therapy, do it well. I think our statistics kind of show that, the ventilator is not a death sentence. While of course, everybody tries to avoid putting on the ventilator, we still think it's a viable and important tool in the toolbox. And to be, again, pay attention to this hypercoagulable state. There's probably going to be a lot more published about that soon. And people survive the ICU. And I think all our efforts continue to be worth it. I'll keep saying that. Thank you.
Thanks, Mark. You just keep putting that up on the slide. Continue to be worth it. But before I go to Dr. Brunsfold, who's going to give us an update as well, particularly on PPE, I want to do a couple of things. I want to ask Mark a question, but also I want to tee up some polling questions. So all of you participants that are like, doing a couple emails, all that, kind of like refocus, bring it on back, because we're going to do these really quickly, like 30-second lightning rounds. And so it's going to pop up really fast. And seriously, I don't want to miss the opportunity to see what each of your experiences has been with this. And actually, just so you know, so what happens to them? Well, you're going to see the results just like I am. But also, we're working really hard to make sure that leadership at HHS and the FEMA Healthcare Task Force also sees the results of these too, so they don't go into a black hole. So while you're taking a look at that, don't respond yet, okay? Mark, help me with and you may have said it, but I missed this piece, or maybe you didn't say it. So this issue of lung compliance has been brought up on some previous rounds, the critical care rounds. And you described the two phenotypes. I mean, okay, so there's the two phenotypes with it. Do you have a sense when they first come in, which ones are going to be like, okay, which phenotype they're going to be because of these characteristics, or is it, do they declare themselves over time with your clinical experience with them?
Sorry, I had to unmute. Yeah, so I mean, the problem is that we don't know what they're like before we intubate them. We can't really, we don't.
Okay.
sense of that. So, but once we do intubate them, I would say by and large, people are expressing the normal compliance. I would say that's probably worse for people who have had, bacterial co-infections or have kind of crashed and burned harder. We're trying to quantify that right now by going back through our, vent data and kind of showing, how many people expressed low compliance versus high compliance when they first went on. But I would say by and large, we have noticed primarily the high compliance.
And okay, so really quick follow-up. Tell me, so has that the compliance changed your fluid management strategies?
No, so our fluid management by and large has been mostly to keep them on the dry side, or euvolemic, I would say is probably the better term. A lot of them do require some initial resuscitation, but I'd say pretty rapidly, they're not in septic shock by and large. And even if they are in septic shock, we do the initial resuscitation and then try and get them dry again as soon as we can. So I think just that continues to be a good practice to keep them on the dry side.
Okay, thank you. Thanks, Mark. Okay, so we're lightning rounds in terms of responses to these polling questions. We're going to do the first one when I say go, and we'll do like 15 seconds. That's a really straightforward one, sort of like, in the past 7 days, is your access to PPE while caring for patients better, worse, or the same? So it's your access. I'm not talking about like numbers in stock, but your personal access to PPE while caring for patients. Is it better, worse, or the same? And I'll say go and then stop in just a second. Ready, set, go. About 3 seconds left, and we'll stop. Nail, stop. All right, so can we see the results of that yet, or like I have to go through the other ones, Bruce?
Rick, I think we need to go through all of them.
Okay, all right. So the second one, and actually, Bruce, I need some help with this. Actually, I think we're good. What I noticed is on my screen, it cut off the last option, which was helmet-based ventilation. So for those of you that have the similar kind of screen, you got to scroll down or up, whatever, to make sure that you see all the 5 choices there, five choices. So this second question, we'll do 30 seconds on this one. Which of the following strategies are you using for ventilation support for critically ill COVID patients? Choose all that apply. Okay, so you put checks by each one of them that apply. So when I say go, and then I'll do 30 seconds. Ready, set, go. About 5 seconds left for this one. Okay, stop. All right. And the judges' scores are, I don't know, can we get them up maybe? All right. Fascinating. Melissa, when we get to your talk, I'll be fascinated to see your thoughts on question 1. Yeah, interesting. So better, 23%, worse, 9%, and same, 68%. And then which of the following strategies are you using for ventilation support for critically ill COVID patients? Choose all that apply. Early intubation was 43%, high flow nasal cannula, 50%, CPAP, 32%, BiPAP, 27%, helmet-based ventilation, 9%. And I'll be fascinated to talk about that a little bit too. So, okay. So if we can make sure that that screen's available again, Bruce, that'd be great if that's available. So with that, I'm going to turn it over to Dr. Melissa Brunsfold, the Associate Professor of Surgery and Program Director for the General Surgery Residency at the University of Minnesota. So Melissa, welcome back. Melissa was in the, inaugural class of speakers along with Mark, and she's also provided another update as well, and anxious to hear about PPE conservation, which is a topic of it's a topic of every Rails that we have. So Melissa.
Yeah, thank you. I just want to make sure I'm not on mute. Okay, good. So thank you for inviting me back. These have been really informative. I can't tell you how much, even I'm taking home a ton of information every time. So thank you very much for doing these. I really appreciate them myself. So it's been great to be a part of this group. I'd like to talk for a few minutes about PPE conservation. And one of the things I'd like to hear, again, sort of hive mind, I'd like to hear from everybody about what you guys are doing in your institutions. So please fill up the chat with your ideas, starting right now, about interesting things that you're doing. Please share. Everybody should start telling us what it is that you're doing to conserve PPE, any ideas that you have. I don't have any disclosures as it relates to PPE. And let's see, I'm not getting it to move forward here. So PPE is obviously critical to our work. And yesterday, it just came out, this heartbreaking story was published yesterday, that over 150 doctors have died in Italy now from the virus. And so I think it's really critical that we have the opportunity to protect ourselves as best we can from the disease. This is our own institution, caring for somebody. We have all of these different machines and devices and things that the nurses and respiratory therapists have to go in and out of the rooms to attend to CRT and ECMO and ventilators and different things. And it's really critical that everybody have the equipment that they need to protect themselves. So in Minnesota, we have been relatively protected from the virus. We have not really been hit. You can see we're the bottom line. We have really flattened the curve. So in terms of cases per 100,000 people, we only have 64 cases per 100,000 people. We have the flattest line there of all the states. There's sort of a joke about us. We're the land of the Norwegian bachelor farmer, right? So we're already a little bit socially distant. Somebody said when they said we should be 6 feet apart, Minnesotans thought that seemed a little bit too close in the first place. So there are a number of our counties that don't have any disease. And I think when the fishing opener comes in later in the spring here, I think some of the folks from the metro area, this is the Minneapolis, St. Paul, sort of our metropolitan area here, folks will go up to the fishing areas, and I think we will start to see a little bit more disease in the outstate area. So Minnesota we have had a really good job of flattening the curve, but I'm not certain that that's gonna persist. But as a result, we have not been, we've been deprioritized in terms of getting PPE. So on the Minnesota Department of Health website, they post the orders for PPE and where we've been, where we are in terms of these deliveries. So you can see here the quantity ordered of each of these things, surgical masks and gowns and things like that, how many millions of these things have been ordered, and how far out they are in terms of deliveries. And some of them, surgical masks, it's unclear when we'll ever get them. So it's quite far out on some of these things. 1.5 million and N95 respirators, it's unclear when we'll ever get them, out of this order. And so that's because we've been deprioritized, I think. So I think the number one thing, my advice, number one thing is communication. So we got to communicate about this, where we stand on this, because this is the thing that builds trust. So it builds trust. You have to communicate with the folks that you're working with. It fosters a partnership. It helps to foster the partnership that we're in this together. We're going to solve this. And then it unlocks the creativity of the folks that you're working with to try to figure out how to solve some of these problems. So you can see here, this is from the NHS in Great Britain. Folks are washing these nitrile masks. They're washing things, you know, that, I mean, we would have all gotten citations. Nobody would have ever done this sort of thing in the past. You would never would have washed these things in the past. So this is the thing. So this is the daily communication that comes out from our institution. We get this daily in the email. It's our system supply dashboard. We didn't get this to start with, but people quickly realized from the incident command center that people wanted to know why it was that we were, you know, in this PPE conservation mode. So in our daily email, as one of the bullet points, we get this to increase transparency, to have a better understanding of why we're having these specific things. You know, it doesn't say specifically how many of each of these things we have, how, you know, where we're at, but it just gives an idea. This is why we're in these different modes. So we're in green for surgical masks, we're in yellow for face shields and gloves, you know, we're in red for gowns. So this week, for example, we implemented a new policy that if you're caring for two COVID patients, you wouldn't change the disposable gown, the cloth gowns. If you're wearing cloth gowns, you would wear the cloth gown from room to room. If you're caring for COVID patients, two COVID patients, you would wear the same cloth gown between those two rooms. Now, if one of them had an additional infection such as MRSA, you wouldn't do that. But, and people understand why that is when they have the information, they can understand why something like that is. And so I think the communication, again, is very, very key. And then, like I said, it unlocks these innovations. And so we live in, you know, 3M stands for Minnesota Mining and Manufacturing. So we live in the area where 3M is just down the street from us. And so 3M has been mobilized to provide a lot of these things. Again, they're being shipped out of the state to provide for places where the disease is hitting a lot harder. And so folks are coming up with some of their own solutions. People are doing a lot of 3D printing, I think, in some of the wood shops and schools. You've been seeing that people are doing 3D printing of either face masks or different kinds of things like that, face shields. We have one of these units where people are doing UV sterilization of masks. Now, when I first heard about that, I thought, as a surgeon, I thought the person who thought of that has probably never worn a mask, right? Because you would want to get your own mask back. As somebody who has sneezed in about 1,000 different masks, you want to make sure to get your own mask back. So these are all labeled, and then we get, in our institution, we get our own mask back when that happens. So you get your own mask back. And then we have, in our institution, we'll get a rotation. So you have a mask that goes in a paper bag, and then that bag is allowed to sit for 5 days, which is the period of time that the mask is felt to take, where it's felt that the virus then is gone, and then the mask can be reused after 5 days. And so that's the idea. And then people are coming out with, you know, we've seen many people who have N95 masks that have been for business use of a variety of different kinds of business use, either painting or Apple had millions of masks that they were using that they had for industrial purposes that have been repurposed to bring into the healthcare space. And so I think that that's one of the things that people have been doing. And then also the variety of industrial uses that people have been doing. So I'm also the general surgery program director. And one of my colleagues said that she went out and bought raincoats for all of her general surgery residents. And she put them all in the call room. And she said, you don't have to use any of these raincoats, but I want to let you know that there are raincoats in the call room so that if we ever run out of PPE, if there's ever a situation where you feel like there isn't PPE for you, then there's PPE in the call room. There'd be a raincoat for you that you can go and get. And people have obviously sort of a famous story about people creating protective devices out of garbage bags. And so, like I said, people have unlocked some innovation and creativity because they feel like they're in it together, because they understand what the situation is, to create some PPE out of their own creativity. So those are my thoughts about PPE conservation and creation.
Thanks very much. And what's the dashboard, that transparency piece that you spoke about. The transparency piece, while when you said it's sort of like self-evident, but that dashboard seems to be like a great model to emulate if others aren't doing that. It really does. And how often is that updated?
That's updated every weekday. It comes out every weekday from our incident command in our hospital. So I think like I said, I think it's really key because again, it fosters this idea, this partnership. You know, we're in this together, and people understand. You know, it's going to change. Things are going to change, but people know that we're in this together.
Thank you. So we've got like 8 minutes. I'm trying to figure out how to best use that time. There's
some really great ideas here in the chat about things that people are doing. So UV light, people are talking about UV light in their. People are saying they built UV light things to re-sterilize their masks. People are saying they reuse their masks for 3 days. Surgical masks are worn for shifts and then discarded. How about you guys? Mark, what are you guys doing to conserve PPE?
Melissa, can you bring the slides down so we can get back up on the?
Oh yeah, sorry.
That's all right. It's okay. Yeah, great.
Yeah, sorry. By the only PPE we're really, we are asking people to conserve the facial masks that they wear in the hospital, around the hospital, but not in the patient rooms. But the N95 masks, we have a system where they can leave them in a bag. It gets sterilized overnight by UV, and then they're able to pick them up the next morning, or they're delivered back to the unit the next morning. So I think we're doing fairly similar things. We have thought about reusing the yellow gowns, and they have been doing some experimentation with that, with sterilizing them in a similar fashion. It's been difficult because people's habits is to tear them off, which is kind of useless.
Yeah, we were trained for so long, right, that all of these things were single use.
Yeah, it's very hard.
Heather wrote that people have set up iPads for the negative pressure rooms to try to avoid, to be able to have conversations with the patients, to be able to avoid going in and out. We do that. I see Sharon's nodding. A lot of people are using different ways of conversing without having to go in and out of the rooms.
Yeah. We bought 300 baby monitors for that.
Baby monitors.
So let me get to Paul. I know Paul's been using some strategies on PPE at Mass General that might be useful to share too.
Yeah, he put some comments in.
Yeah. So we've had extended use and reuse policies for both surgical masks and for N95s for some time. We are using a vaporized hydrogen peroxide strategy for reusing, for decontaminating our N95s. We've decontaminated more than 20,000 of them. We have tried strategies both to get them back to the index user where you get your own back, as well as ones that give back batches. And both have been successful. I think people tend to prefer the index user strategy. I posted in the chat that we posted our version of how to do that. It is moderately labor intensive, but actually working really well. We have people that are very happy to get their respirators back and have been using them multiple times. We use them up to 5 times before they're thrown out, although our system's actually validated for up to 20 times, but we stop at 5.
Somebody commented or had a question about UV light damaging the fibers. Are you guys familiar with that? I'm actually not familiar with that. And so that was a question probably we should, damaging the fibers of the N95 masks.
So I'm out of my depth here, but I'll encourage folks to go to the experts on this one. Part of what makes an N95 filter well is an electrostatic charge, and every method preserves that electrostatic charge. And so there are published data out there on the methods that people have been talking about with either vaporized hydrogen peroxide or UV light. There's a great link at the Nebraska website. Would encourage folks to look, but make sure you're using a validated method, because unfortunately, if you destroy that charge, the respirator does not filter effectively.
Yeah, the CDC has a good comprehensive list of what to do in the various stages too, in terms of if you're in conventional versus contingency or crisis, about what's okay to do in terms of PPE conservation. I meant to include that link for folks to refer to.
Melissa, thanks for the PPE presentation and the PPE discussion. I want to go to, can we pull up the polling for just a second again? So I want to go like lightning rounds, like a minute apiece. Each of the panelists and the speakers reactions to the responses to question 2, where we had, because ventilation support continues to be a national, probably international dialogue on how to best do this. So your reactions to the responses we got. So we'll start with Melissa and then just go counterclockwise. Melissa, what do you think about the ventilation support strategy responses?
So I think it is a great idea to avoid intubation if possible. I do think we used to think that we couldn't use these high flow nasal cannula or CPAP or BiPAP because they would be aerosolizing and a risk to other staff, hospital staff, and I don't think that's the case anymore. I think the helmet-based ventilation is a great idea, and I think that early intubation is probably not necessary in terms of avoiding infectious risk.
Thank you. Mark. Gotta go off mute, Mark. Lower left-hand corner, at least on my screen.
Mark, it's Matt from IT. If you just select on your screen approve to unmute, you should be good.
There you go.
I apologize. No, I'm working on a tiny laptop. And I also apologize that I'm afraid I missed the questions.
No, it's okay. So you saw the ventilation support strategies responses there. What's your reaction to those?
I think it's interesting. I think I think it's pretty typical that I think people have been using a variety of things. I think there's some definitions about what qualifies as early intubation. I think everybody has a different idea what that means in their minds.
Good point. Yeah.
I would say, what's interesting is the CPAP and the BiPAP, which I think a month ago would have been unthinkable. But probably, I think the BiPAP I'm still a little concerned with, just because of the patient self-induced lung injury. But the CPAP may have a role, and that's underappreciated. So I'm glad to see that people are becoming a little more, I think, rational about some of these fears with using these modalities. I think they need to be explored.
Thanks. Sharon, you teach a lot of people, and you hear from a lot of people. So with the National Emerging Special Pathogen Treatment and Education Center. So what's your reaction to those responses?
I echo what Mark has said, coming from the same institution, I could not agree more, and would love to hear from our other subject matter experts on the panel. But I was a little bit surprised by the BiPAP as well, because I know that at our institution, we have definitely limited BiPAP.
Thanks. Paul?
Yeah, I think I like Mark's comment about early intubation meaning different things to different people. I think we very much believe that self-induced lung injury is a real thing, and that there are definitely times where intubation is preferred, and we think our experience so far is bearing out that these people do better. But we've certainly done a fair amount of awake proning, and I think we've had a number of people who avoided intubation with that. I don't think we intubate as quickly as we might otherwise, but especially folks that are working hard, we don't let them go very long.
Thanks, Paul. And then Allison, I got two questions for you. Well, same one about the reaction, but specifically, what did you think about the helmet number or percent? What do you think?
To be honest with you, I think I may have some of my colleagues on the line with us today.
Sample.
So some of that may be coming out of my institution, although I know there are other institutions that are, if not using the helmet, are considering using the helmet going forward.
So what is the, then another follow-on question. So what's the rate limiting step to an institution like plowing in and saying, I'm going to use this? I mean, what, from your perspective? Because you're obviously pioneering with it in a lot of respects.
So I think probably the biggest kind of institutional problem that we may have with the helmets at this point in time is that C-Long is actually a very small company. So they do have a little bit of a backload on orders right now. So it may take a little bit of time. There may be a delay actually getting the orders to the institutions that do order them. But I think it's worth considering if it's something that you'd be interested in, and placing orders, even though it may take a little bit of time to get the orders actually to the hospitals.
Okay, and your overall reaction to the responses there?
I'm a little bit biased based on the presentation that I gave today, looking towards finding other methods as far as taking care of our patients aside from kind of early intubation at 5 liters nasal cannula. So I am encouraged that people are trying other things. But I think I would like to echo that there are certain patients that, regardless of what else we have to offer, do still need to be intubated. And I think looking at things like respiratory rate, work of breathing, things of that nature pushed me towards thinking that these patients are not going to benefit from things like non-invasive ventilation, and we do tend to intubate those patients a little bit earlier.
Great, thank you. So we're like a couple minutes after the hour, and Dr. Strominger, I want to turn it over to you. If you have Dr. Strominger, so he's on the Hollywood Squares there, but he's like tracking all these questions extraordinarily well, better than I do. And Bruce, if there's a specific question that you want to make sure you get a chance to ask the panelists, do so. If you think we're time and we need to do the end housekeeping slides, that's fine too, and then we'll close.
Great, thanks, Rick. Maybe just a quick question to our panelists about what you're noticing about the profiles of the patients in the ICU who are ventilated, who tend to do better or tend to do worse. To what extent you're able to see commonalities of patient profiles that are not doing well versus those that get off the ventilator and go home. I don't know if Mark or Allison, you could make a quick comment about either of those.
I think I could start with that. First of all, I want to say, this disease process, while it has features of ARDS and features of a disease that causes renal failure and things of that nature, it's a new disease to us. And I have to say that, the longer and the more I work in the ICU, the more I realize that we don't have this figured out yet. And sometimes it's very difficult to see kind of early on in the stage who is going to end up intubated for 3 weeks and who we're going to be able to get off the ventilator in 1 week. Sometimes inflammatory markers may be helpful to us. Sometimes early, kind of the first 24 hours with diuresis and seeing how they do. But I can't say that I have a perfect strategy to determine who's going to do well and who's going to struggle.
Great, thanks for sharing that. Mark or Melissa, any additional comments?
I think again, I think it is similarly difficult to predict. We're getting a better handle that the ones who I think it's kind of obvious if they have the low compliance, that probably they're and develop true ARDS, that probably their chances are worse, and that's probably just because of the we know that for ARDS data that their likelihood of survival for severe ARDS is probably still around 50 or 60%. So it would make sense that they're going to do worse. But they're few and they're not the common. So I think by and large, we can expect, at least by our survival data, about 75% of people to be come off the ventilator, and so far we've had 50% of those be discharged to the floor, and a large percentage of those discharged to home. So I think again, for us, the ventilator, we think is a successful strategy, and that by and large, people are going to survive and go home on it.
Great. Thanks, Mark. I think in the interest of time, my last comment will be, please take advantage of the CME opportunity and take the quick survey to give us feedback on how we're doing with these clinical rounds and how to improve them. And just thanks to all our presenters and to all the attendees for spending the last hour with us. Back to you, Rick.
Yeah, thanks. Everybody's got to get back to the bedside, do rounds, get a quick bite. Don't forget to hydrate up, take care of yourselves. In terms of the participants, great participation by the participants. I mean, in the chat and in the polling and so forth, so on, is extraordinarily informative. To us and the speakers, just an awesome discussion of like the real deal issues. And especially appreciate the humility that each of you have around this disease, which I share with you. And now is not the time for dogma, for sure. With that, thanks all, and be safe and well. Bye.
Take care. Thanks.